Hello and welcome to A Sound Constitution here on CHOY 101.7 FM, a show where we focus on health topics important to our community. This year's team is made up of 4 fourth-year VIU nursing students, and our goal is to demystify health issues and address common misconceptions by sharing evidence-informed information from a variety of reliable resources. All information provided on our show will be available in our show notes, on our Facebook, Instagram, and Twitter pages. We want to remind our listeners that the information presented in this show is for educational purposes only and does not replace the advice of your primary healthcare professional. If you have any questions or concerns about what's being discussed, feel free to reach out to us on Facebook at A Sound Constitution, Instagram at CHLY A Sound Constitution, all one word, Twitter at ASC_VIU, or email us at asoundconstitution@gmail.com. We would like to start our show by acknowledging that we're on the unceded territory of the Snuneymuxw people, with a broadcasting range that overlaps the Powhatan and Sliammon territories. This acknowledgement is done with gratitude to the Snuneymuxw people and with the intention to increase awareness about truth and reconciliation processes and efforts on Vancouver Island. Additional information and resources surrounding Snuneymuxw history, reconciliation, protocol, and land acknowledgement can be found on our Facebook, Instagram, and YouTube pages. I'm your host, Habin, and today our episode is on diabetes and obesity. We're going to talk about types of diabetes, the different ways to control it, and the health impacts, because chances are diabetes affects you or someone you know. We will also cover topics about obesity and the weight stigma around it later in the episode with our featured guest, Brenda Lane, one of my favorite professors at Vancouver Island University. Diabetes is one of the most common chronic diseases affecting people living in Canada, with around 11 million Canadians either with prediabetes or diabetes, according to the Canadian Diabetes Association. The World Health Organization, WHO, has identified diabetes as one of the major public health challenges of the century. Additionally, according to the World Health Organization, it's really important to have an understanding of diabetes and ways to reduce the risk, since its complications can lead to heart attack, stroke, blindness, kidney failure, and lower limb amputations. Despite the popular belief, people don't give themselves diabetes. A lot of people have a misconception thinking that it's their fault for eating too much sugar, but diabetes can be caused by factors that are out of people's controls. According to the Canadian Diabetes Association, it could depend on your genes, family history, ethnic background, and other factors such as the environment and your health. Also, the reason why someone will develop type 1 diabetes will be really different in the reasons why another person will develop type 2 diabetes. And now, I will pass over the mic to Cameron, who will talk about the different types of diabetes.
Thanks, Habin. I'm going to discuss the different types of diabetes, including type 1, type 2, gestational diabetes, and prediabetes. To begin our conversation about the different types of diabetes, let's do a quick overview of generalized diabetes mellitus. Diabetes mellitus is often simply referred to as diabetes and is a chronic health condition where your body is unable to produce and utilize insulin. Insulin is secreted by your pancreas and is a hormone that regulates blood sugar levels and allows your cells to use the sugar in your blood as energy. If your body is not properly producing or utilizing insulin, your blood sugar levels will increase and can eventually damage your organs and body systems. It is important that we talk about diabetes because according to Diabetes Canada, every 24 hours in Canada, more than 20 Canadians die from diabetes-related complications, 400 more people are diagnosed with diabetes, and 14 people are having lower limb amputations. There are 3 different types of diabetes as well as prediabetes. I'm going to talk about each type of diabetes, the signs and symptoms, and treatments. To get started, let's talk about type 1 diabetes. Type 1 diabetes mellitus is an autoimmune disorder where the pancreas is unable to produce insulin and therefore cannot regulate their blood sugar. Type 1 diabetes is often referred to as insulin-dependent diabetes because it is necessary to supplement with insulin every day to manage blood sugar levels. According to the Centers for Disease Control and Prevention, only 5 to 10% of people with diabetes have type 1 diabetes, and the major risk factor is family history. In other words, type 1 diabetes is not caused by external factors such as diet and exercise, but rather genetics. The CDC also demonstrates that because type 1 diabetes is an autoimmune disorder, it is often diagnosed in children and teenagers. However, people of all ages can be affected. It can often take time to develop and notice symptoms of type 1 diabetes. However, once established, they can be severe. Signs and symptoms of type 1 diabetes may include increased thirst and urination, increased hunger, unexplained changes in weight, blurred vision, and general feeling of weakness and fatigue. Unfortunately, type 1 diabetes does not have a cure and is primarily treated through insulin, diet, and lifestyle to manage blood sugar levels. Monitoring blood sugar levels is made easy by using something called a blood glucose meter. There are different types of blood glucose meters. Some use small amounts of blood samples to determine glucose levels, whereas others scan a small sensor that is implanted under the skin. With type 1 diabetes, insulin is administered daily through injection or an insulin pump to regulate the blood sugar levels. Diabetes Canada recommends participating in regular daily physical activity, maintaining a healthy body weight, and managing stress to help decrease adverse side effects of type 1 diabetes. It is also important to note that there can be potential complications that accompany type 1 diabetes. According to Diabetes Canada, people with type 1 diabetes are at increased risk for celiac disease, kidney disease, diabetic retinopathy, heart disease and stroke, high blood pressure, nerve damage, amputation, and mental health challenges. This list is daunting, I know, but there are ways to help prevent these complications. Diabetes Canada has many links to resources and tools to help support people with type 1 diabetes. Our show notes will also include a quick link to access the Diabetes Canada website. In addition to type 1 diabetes, there is also type 2 diabetes. Type 2 diabetes is when your body cannot make enough insulin or does not properly use the insulin it makes. Type 2 diabetes accounts for 90% of diabetes cases in Canada. Risk factors for type 2 diabetes include family history, inactivity, being overweight, and being over 40 years old. Symptoms of type 2 diabetes include unusual thirst, frequent urination, change in weight, extreme fatigue, blurred vision, recurring infections, slow wound healing, and tingling in your hands and feet. Many of these are similar to type 1 diabetes symptoms. For the treatment of type 2 diabetes, the focus is on maintaining blood sugar levels. You can manage type 2 diabetes through lifestyle by having a healthy diet, participating in physical activity, maintaining a healthy body weight, and managing your stress levels. If lifestyle changes do not help your blood sugar levels reach a manageable level, you may need to supplement with insulin. It is important to properly treat insulin because untreated type 2 diabetes can lead to life-threatening situations. Complications of type 2 diabetes are similar to that of type 1. They include but are not limited to kidney disease, diabetic retinopathy that can lead to blindness, heart disease and stroke, high blood pressure, and even nerve damage or amputation. The third type of diabetes is called gestational diabetes. Up to 20% of pregnant people will develop gestational diabetes during their pregnancy. Gestational diabetes is interesting because the pregnant person usually does not have diabetes prior to being pregnant and will not have gestational diabetes after the birth of her baby. So why do women develop gestational diabetes? Gestational diabetes is caused when the pancreas is unable to create enough insulin to support the mother and growing fetus. Throughout the pregnancy, the pregnant person's body goes through hormonal changes which impact the body's use of insulin, resulting in increased insulin resistance. This is a normal part of pregnancy. However, some women may have previous insulin resistance or too much, which causes blood pressure levels to be too high during pregnancy. Risk factors for gestational diabetes include being overweight, being physically inactive, advanced maternal age, and family history of diabetes. During the second trimester of pregnancy, the pregnant person will undergo a gestational diabetes screening test that uses a fasting blood sugar sample and a blood sugar sample 2 hours after ingesting a sugary drink to determine blood sugar levels. It is important to treat gestational diabetes and manage blood sugar levels during pregnancy because increased blood glucose can result in pregnancy complications such as preeclampsia, abnormal sugar levels for the baby, increased fetal growth, and possible injury during birth if the baby increases in size. Many pregnant people are able to maintain blood sugar levels and control gestational diabetes through diet, physical activity, and/or insulin injections. Although gestational diabetes usually stops after delivery, being diagnosed with gestational diabetes increases the risk of developing type 2 diabetes later in life. It is important to be tested for type 2 diabetes 6 weeks to 6 months postpartum, while planning subsequent pregnancies, and every 3 years after giving birth. Although there is only 3 types of diabetes, sometimes you may experience increased blood sugar that isn't quite high enough to be diagnosed as diabetes. This is referred to as pre-diabetes. Having pre-diabetes does not mean you will definitely acquire diabetes. However, it is a major risk factor. To prevent and delay the development of type 2 diabetes, it is important to uphold a healthy lifestyle. The symptoms of prediabetes are the same as those for type 1 and type 2 diabetes. Later in the episode, Taylor will discuss ways to promote healthy lifestyle choices.
According to Diabetes Canada, 1.7 million Canadians have type 2 diabetes and don't know it.
According to Diabetes Canada, diabetes is the cause for 30% of strokes, 40% of heart attacks, 50% of kidney failure requiring dialysis, 70% of all non-traumatic leg and foot amputations, and is the leading cause of blindness.
Here are some tips from HealthLink BC about eating out when you have diabetes. Plan ahead. At restaurants, check for online menus that include nutritional information before you go. Most restaurants have information about the carbohydrates, calories, sodiums, and fats in their food. You can also buy a pocket guide or an app for your phone with nutritional information for common foods.
Welcome back to CHLY 101.7 FM. You're listening to a Sound Constitutions episode on diabetes and obesity, with Taylor coming up next to talk about diabetes management.
Hello, thanks for tuning in. This is Taylor, and for this episode, I will be discussing diabetes management. The information I will be providing comes from Diabetes Canada, healthline.ca, and from a textbook we use a lot in the nursing program by Lews et al. Called Medical Surgical Nursing in Canada, Assessment and Management of Clinical Problems. As always, I will include these resources in our show notes, so be sure to check them out if you would like more information. To begin, I'm going to discuss diet and give some tips for managing diabetes. It's important to note that Diabetes Canada recommends that all people with diabetes should receive advice on nutrition from a registered dietitian to help choose a diet that is right for you. Diabetes Canada recommends choosing lower glycemic index foods more often to help control blood sugar. Glycemic index, or GI index, refers to a numeric value that is assigned to foods based on how slowly or quickly they can increase your blood sugar levels. This is due to how quickly or slowly foods are digested and absorbed, and this has a lot to do with the types of carbohydrates found in foods. So a lower glycemic index means that these foods have a slower, lesser effect on blood sugar levels and will not cause large increases quickly. A low GI diet can help decrease complications associated with diabetes, make you feel full longer, and help maintain a healthy weight. Foods are categorized as low, medium, and high GI. Diabetes Canada provides a comprehensive list of examples in each category, so be sure to check them out if you'd like more information. According to Diabetes Canada, the following are diet tips and recommendations for those living with diabetes. Eat 3 meals per day at regular times. Limit sugar and sweets. Try to limit the amount of high-fat foods you eat that can cause weight gain. Eat more high-fiber foods that can help you feel full and can lower blood sugar and cholesterol levels. Try preparing meals at home using whole, unprocessed foods. Limit alcohol consumption. Make water your drink of choice and avoid sugary beverages. Lastly, watch your portion sizes. Weight loss is the most important and effective way to normalize blood sugar levels and reduce the risk of other health conditions. Next, I will be discussing the importance of physical activity and providing some recommendations from Diabetes Canada. Regular physical activity can help control your weight and reduce the risk of diabetes complications like heart disease and stroke. It also helps prevent sugar from building up in the blood, lowers blood pressure, and can help reduce the risk of developing type 2 diabetes. According to Diabetes Canada, regular physical activity, especially for those with type 2 diabetes, is one of the most important things you can do to lower your blood sugar and can sometimes work as effectively as some medications. Diabetes Canada recommends avoiding long periods of sitting by getting up and moving around every 20 to 30 minutes. Aim for 150 minutes of aerobic exercise per week. This includes activities such as walking, jogging, and cycling. Try incorporating interval training into your workout routines to increase fitness level and lower the risk of low blood sugar. And aim to do resistant exercises 2 to 3 times per week. Before getting into hypoglycemia and hyperglycemia, I'm going to talk briefly about blood glucose monitoring because this is a hugely important part of diabetes management. Blood glucose, also called blood sugar, is the amount of sugar in your blood at a given time. Checking your blood glucose levels tells you if you have high or low blood sugar at a given time and also helps you recognize how lifestyle, such as the things you eat and medication, affects these levels. According to Diabetes Canada, ideally, a fasting blood glucose level, this means before meals, for someone with diabetes should be between 4 and 7 millimoles per liter. 2 hours after meals, it should be between 5 and 10 millimoles per liter. There are a few ways that blood glucose can be checked. The first is using a blood glucose meter, which requires a finger prick using a lancet. There are also flash glucose meters available that use sensors that are inserted under the skin and that can be scanned to display blood glucose levels. Another device is a continuous glucose monitor or CGM. These work by continuously checking blood glucose levels throughout the day, also by using a sensor inserted under the skin. Blood glucose levels are then relayed in real time to a device such as a smartphone. A CGM can also be paired with an insulin pump called an integrated CGM that can automatically adjust insulin delivery based on the blood glucose readings. It's important to talk with your healthcare provider to determine the device that best suits your individual needs. Now I'm going to talk about hypo and hyperglycemia, including the signs and symptoms and what to do if this occurs. Hypoglycemia means low blood sugar and occurs when blood sugar levels drop below 4 millimoles per liter. Mild to moderate low blood sugar can cause nausea, lightheadedness, confusion, hunger, headaches, weakness, increased sweating, and an increase in heart rate. When hypoglycemia is severe, meaning that blood sugar levels have dropped below 2.8 millimoles per liter, it can cause confusion, disorientation, loss of consciousness, and seizures. If loss of consciousness occurs, it's important to call 911 so appropriate treatment can be received. Some causes of hypoglycemia include not eating on time or eating less than normal, more than normal physical activity, taking too much medication, and consuming alcohol. If you are experiencing any symptoms of hypoglycemia, it's important to act quick and check your blood glucose levels immediately as blood sugar levels can become dangerously low quickly. Diabetes Canada outlines what you should do if your blood sugar is low. First, eat or drink 15 grams of a fast-acting carbohydrate. The ideal choice would be glucose tablets, but if you don't have these on hand, some other options include 1 tablespoon or 3 packets of sugar dissolved in water, 2/3 of a cup of juice or regular pop, 6 hard candies such as Lifesavers, or 1 tablespoon of honey. After this, you will want to wait 15 minutes and recheck your glucose level. If still low, try the same amount of fast-acting carbohydrate, waiting 15 minutes between, and checking blood glucose again until above 4 millimoles per liter. If your blood glucose level is above 4 millimoles per liter and your next meal is within the hour, you don't need to do anything. If your next meal is more than an hour away, have a snack such as half a sandwich or some cheese and crackers. High blood sugar is called hyperglycemia. It occurs when your blood glucose levels are at or above 11 millimoles per liter. Some symptoms associated with hyperglycemia include tiredness, thirst, and frequent urination, especially at night. Hyperglycemia happens most often when food, activity, and medications are not balanced, but can also occur due to stress or illness. If hyperglycemia continues to occur, it's important to speak with your healthcare provider as they may recommend adjustments to your meal plan, exercise regime, or medications. Lastly, I'm going to talk about insulin and other medications used to manage diabetes. I will start by giving a quick summary of insulin and how it affects blood glucose levels. Insulin is a hormone made in the pancreas and it allows your body to use glucose for energy. After eating, the carbohydrates from food are broken down into glucose and absorbed into the bloodstream. Insulin then signals cells to absorb this glucose to be used for energy. When there is too much glucose in the bloodstream, insulin signals the body to store leftover glucose in the liver. According to Lews et al., under normal circumstances, insulin is continuously released into the bloodstream in small increments, also called a basal rate, with an increased release known as a bolus when food is ingested. Injectable insulin is needed when there is inadequate insulin in the body to meet its needs and maintain appropriate blood glucose levels. According to Healthline.com, people living with type 1 diabetes always require the use of supplemental insulin as their bodies are unable to produce insulin. Those living with type 2 diabetes may also require the use of supplemental insulin if they're unable to manage their blood glucose levels with lifestyle changes or other oral diabetic medications. There are numerous types of insulin and they differ in regard to how quickly they work, how long they work for, and when they are most effective. According to Lews et al., the most common insulin regime is the basal bolus regime. This means that a rapid or short-acting insulin is used as a bolus before meals, and an intermediate or long-acting background insulin, referred to as a basal, is used once or twice a day. Most often, two different types of insulins are used: a short or rapid-acting insulin and a long-acting or intermediate insulin to provide mealtime and longer-term daily coverage. Your healthcare provider will determine which regime is best for you, and factors such as age, activity level, and how your body reacts to the insulin can help with this decision.
Thanks, Taylor. Now we're going to take another short break. According to Obesity Canada, 64% of adults with obesity report experiencing weight bias from a healthcare professional.
Here are some definitions from Obesity Canada. Weight bias refers to negative attitudes towards others because of their weight. Weight stigma refers to stereotypes and labels we assign to people who have obesity. Weight discrimination refers to actions against people who have obesity that can cause social exclusion and inequities.
In a recent journal article by Alberga et al. Examining weight bias among practicing Canadian family physicians, 24% of physicians indicated disliking or having a discomfort with friendships or acquaintances with the people with obesity. About 50% agreed that people with obesity increased demand on public health systems. 33.3% indicated feeling frustrated with patients who have obesity, including 27.8% who believe people with obesity are often non-compliant with treatment, and 18.5% indicated feeling disgusted when treating a patient with obesity.
Hello and welcome back to A Sound Constitution on CHLY 101.7 FM. You're listening to an episode on diabetes and obesity. If you've missed Cameron's section on the different types of diabetes and Taylor's explanation of the management of diabetes, I highly encourage you to go to our YouTube page at A Sound Constitution to have a listen. And now, let's talk briefly about prevention. And when we talk about prevention of diabetes, we're usually talking about preventing type 2. Safe and effective ways to prevent type 1 diabetes have not been identified so far, even though there has been lots of research in this area. However, type 2 diabetes can be prevented or delayed for many people, according to Diabetes Canada. To reduce the risk, Diabetes Canada encourages you to eat healthy, move more, and lose weight if you're overweight. According to the Canadian Diabetes Association, if you have high blood sugar or prediabetes, having an eating and exercise plan that helps you lose just 5% of your initial body weight can delay or prevent type 2 diabetes from developing. However, losing weight by just having an eating and exercise plan may be more challenging for some individuals. Obesity is a chronic health problem that is often progressive and difficult to treat. It is also one of the most misunderstood topics by the general public. Just eating too much or not exercising are not the only components to obesity. There are many other contributing factors on top of diet and exercise that may cause an individual to be overweight. So coming up next, we have Brenda Lane, one of the professors at Vancouver Island University, here to break the myths about obesity and to shed some light on a topic that is often misunderstood. Hello, Brenda. Thank you so much for joining us on A Sound Constitution. How are you doing today?
I'm very well, thank you.
Perfect. Let's get started then. So can you tell us a little bit about yourself and your experiences as a nurse, clinical nurse educator, and faculty member at VIU?
So I graduated way back in 1983. So I've been nursing for 39 years. And I started off my career in the intensive care unit. And then I became a clinical nurse educator for 12 years in both surgical areas and medicine areas. And then I came to Vancouver Island University in 2001. And I've been teaching health sciences, which is pathophysiology courses, as well as clinical practice, as well as lab courses in that time frame.
Mm-hmm. So what are some of the main factors that contribute to weight gain and obesity? Like, are they primarily lifestyle factors, or can genetics play a role as well?
Oh, really good, interesting question. So they have found that genetics do play a role in obesity. They actually had twins, identical twins that were separated at birth. And they found that even though they lived in totally different environments and different family members, et cetera, or not family members, but their secondary families, they found when they pulled those twins together years and years and decades later, they found that they both suffered with obesity, even though they were in totally different environments growing up. They found that genetics does play about a 70% risk of obesity. And there's certain conditions that actually contribute to obesity. And the one that comes to mind is polycystic ovarian syndrome. And women that suffer with this condition are more prone to obesity, extra hair growth, for example, and do end up developing diabetes mellitus as well. So lifestyle factors, you mentioned that. And lifestyle factors, a lot of that is what our society has evolved to being. And when we think of lifestyle, we think of going to the movies. And actually, I just went to the movies last night, and everything's large sizes. So for an extra 20 cents, you can get the extra size drink or the exercise popcorn. And whenever we think of society and there's events, the events are always centered around foods. And people have to just think of their own family and friend gatherings. They always concentrate, okay, what are we going to eat at these sessions? And so that becomes a focus of food around these events. We think of society as a whole, and we realize that in the old days, when I grew up actually, and I'm 62, we used to have the kids going out and playing after dinner or before dinner. And we don't see that as much anymore with kids just playing in the streets. And the reason being is that parents sometimes feel it's not as safe. So what they do instead is all the activities are controlled activities. Parents drive them to their organized sports events. They're still getting their exercise, but it's more of a controlled environment. We see the advent of, sedentary lifestyle jobs where people are sitting more. We see more games. We still see vending machines in schools or in the university, for example. And what's often in those vending machines are unhealthy foods. But we have seen some good changes where they've changed these vending machines to have more water options as well. So those are some things that have been actually good in terms of how things have changed. Oh, the other thing is hormones. So when we think of hormones, a lot of people think that obesity is just related to diet intake and less exercise, but people can exercise, and exercise is only a small portion of a contributing factor. It really is diet intake. And when we think of the hormones that are affected with obesity, there's a couple that I'd really like to concentrate on. And the first one is leptin. And leptin is a hormone that suppresses the appetite and the hunger. And what they found with people suffering with obesity is that they have a resistance to this leptin. And so therefore, they really never suppress their appetite. So they're always hungry. If we could have society thinking about that when they look at people to realize that there is a hormonal component. The second one is ghrelin, and ghrelin is produced in the stomach, and it actually stimulates appetite. And what they found with people, again, suffering with obesity is that they have frequently high levels of this ghrelin. And so therefore their stomach is always stimulated to be hungry. And so therefore they are always eating. They never feel satisfied. And that's really frustrating for the people living with obesity because they don't have that satisfaction when they eat. They don't have satiety and they're always hungry. So those are two hormones that actually contribute to obesity. And the third one is peptide YY. That inhibits the appetite because it slows down the gastric or the stomach emptying. And what they found with people living with obesity is that these levels are decreased. So they don't have slowing down through their GI tract or their gastrointestinal tract in their stomach. So their food just whips through their stomach. So they're always, again, hungry. So those are some of the factors that come to mind.
That's really interesting. Yeah, I usually go for like a medium size or like a large size because of just the cost is much better. What are some potential complications or health challenges associated with chronic obesity?
Oh, that's a really, really good question because there are so many. So let's just start off with the person and what they would be living like on a day-to-day basis. And when they have the obesity, the biggest thing that bothers them can start being their joints. So they may get things like osteoarthritis in their knees or their hips, or even actually in their feet. And that then contributes to them having pain when they're walking. So they're less inclined to want to go out walking. And then that again becomes a little bit of a vicious circle with them not getting as much exercise. The other one is what we call gastric esophageal reflux disease, or GERD for short. And what happens with obesity as they get a large abdomen, that abdomen ends up putting pressure on their diaphragm and also on their stomach. And what they end up getting is their pressure in their stomach when they lie down after heavy meals, for example, and they get reflux from their stomach into their esophagus. And that can cause things like heartburn they complain about. So elevating the head of the bed on blocks or a wedge cushion can prevent those symptoms of gastric esophageal reflux disease and stop their heartburn. If somebody has asthma and they have GERDs, their asthma can become exacerbated by the GERDs because these gastric secretions are backing up and it can aggravate their asthma. The other one that happens, again, and it's affecting their sleep, is the obstructive sleep apnea. And what happens with that one is the obesity of the fat around their neck ends up occluding when they lie down flat and they're trying to sleep. And so what we end up seeing is they go to sleep at nighttime and then they kind of gasp and wake themselves up. And that's because they're having apneic periods. Now, obstructive sleep apnea is not unique to people with obesity. People can be slim, trim, and athletic, for example, and still have sleep apnea. But people with obesity may be more prone to it. And it can be tested. And then the treatment, of course, is a CPAP machine that people can sleep with. They can have a nasal CPAP, a face CPAP, nasal pillows, or they actually have mouth guards that can actually be fitted that also can treat and prevent their sleep apnea from occurring. And the complications with sleep apnea can end up being poor wound healing. They can end up being irritable. They're not getting as much oxygen when they're sleeping at nighttime. So then this contributes to them not doing as well or being sleepy during the daytime. So it's very important with obesity that people have their sleep hygiene looked at to make sure they're getting good sleeping. So the other complication as we kind of go through, the severity of what happens in terms of complications is type 2 diabetes. So diabetes, there's type 1, which is, we used to call it juvenile, but really it can happen up until the age of about 25 or 28. But with type 1 diabetes, the pancreas is not actually making any insulin. And we know that we need insulin in order to help with the control of the blood sugars in our bloodstream. And so what happens with type 2 diabetes, that's usually related to obesity. Type 2 diabetes with obesity can take years and years to develop. But because their pancreas still does produce insulin, they can go on pills to control their diabetes and diet and exercise to control their diabetes. And only if they get to the point years and years later that that's no longer working and the pancreas gets too tired, they then may have to go on to insulin after living with type 2 diabetes. So with type 2 diabetes, there's metabolic syndrome or syndrome X. And these are kind of the precursors to somebody developing or becoming diabetic type 2 diabetes from obesity. So there's a couple of other problems that we see with obesity, and it stems with coronary artery disease and high blood pressure. So people can have high blood pressure that contributes to coronary artery disease. And when we see plaque buildup in the arteries supplying the heart, this is what then contributes to people having heart attacks, for example. This same plaque buildup can occur in the brain. And so patients can also have strokes. So strokes and heart disease are also complications of obesity and high blood pressure. And the last one I want to talk about is a fatty liver. And so people that have obesity, we're talking years of living with obesity, they may develop what's called non-alcoholic fatty liver disease. And the liver can get enlarged, okay? And it can almost feel like there is a stretching of the liver capsule. And the liver is located on the right side of the body. So it's kind of on the right flank, just below right around the rib cage on the right-hand side. And that can be uncomfortable for them. People can also get gallstones. So gallstones are basically cholesterol. The most of them are cholesterol, actually, about 80%. And with the fat that's taken into our body, we have our low density lipids, which are the bad ones. And we have the high density lipids, which are the good ones. But when you're really high in cholesterol or really high in those low density lipids, that's where we see the risk of cardiovascular complications like coronary artery disease, like the hypertension, and then also that cholesterol contributing to gallstones. So those are the ones that really come to mind. Another one that the patients often complain about is low back pain. So usually 1 in 8 people in society will have back pain at some point in their life. But when you're looking at obesity, it's quite common that people will have low back pain. And it's again just centralized around their abdomen.
Let's stop right there and have a short break.
Did you know that according to Diabetes Canada, nearly 6 million Canadians live with pre-diabetes? If left untreated, more than half will develop type 2 diabetes within 8 to 10 years.
According to the Canadian Diabetes Association, people with diabetes are over 3 times more likely to be hospitalized with cardiovascular disease, 12 times more likely to be hospitalized with end-stage renal disease, and almost 20 times more likely to be hospitalized for a non-traumatic lower limb amputation compared to the general public. To anyone who is tuning in right now, you're listening to A Sound Constitution on CHLY 101.7 FM with your host, Habin, interviewing Brenda Lane from Vancouver Island University, here to discuss obesity. Now that we've heard about the basics of obesity, I'm curious to hear about your perspective of diet culture and weight loss medications.
So diet. So there's a really good clinic that's out of Coquitlam, actually, and it's the Medical Weight Management Program. And with that medical weight management program, they have specialists, internal medicine physicians, but physicians and they're called obesity medicine assistants that have trained, and they even have master's degrees in obesity. So this has really taken on a whole different perspective in terms of understanding and treating patients that are living with obesity. Obesity is now classified as a chronic disease. And just with all the complications that I just explained, the medical profession and healthcare professionals have realized that they really need to provide more support to these patients to prevent all these complications that I just mentioned. So part of this in terms of diet, what they say is the best weight is whatever that weight is that the patient's comfortable at, that they can live the best life that they can live in terms of the activities that they like to do. So they don't advocate for one particular diet. And we see people doing keto diets and Mediterranean diet, a high protein diet, a low carbohydrate diet. And the reality is it doesn't really matter, okay? It doesn't matter what diet a person really looks at. It's just as long as if they're obese, that they are losing weight, that it's a controlled weight loss. Usually weight loss should only be about 2 pounds per week. It should not be more than that because you want to have good weight loss. We know that 60% of our body is made up of water, and you can lose water quite quickly and drop weight, but you want it to be that you're actually losing, the fat and not just the water. Your other question was about weight loss medications. When we think about the weight loss medications, the ones that they've used historically, like orlistat, it was a medication for weight loss and maintenance. And what it did was it broke down the fat breakdown and the absorption that occurs in the intestines, which is your bowels. And what they found was people did lose weight with this, but the side effects of this medication were that they had like a lot of flatulence, which is gas. So a lot of gas and a lot of fatty stools that really stunk, and they would kind of float. The fat would just float on the top of the toilet, for example. So that medication, orlistat, was kind of not well tolerated by patients. So they came out with another medication, and this one's an injectable medication. Saxenda is one brand name, and the other one is Ozempic. And these medications were originally used for people with diabetes, but they found with these medications that they were really good for weight loss as well. What happened with these medications is they end up working on the ghrelin, and the ghrelin that's in that stomach, and the ghrelin that's trying to stimulate the hunger. It actually controlled that. And so what happened was these patients were not as hungry, and so they lost weight. And so these two medications, Saxenda and Ozempic, were really good for this weight loss. They are not covered, though, if the patient is not diabetic. If they are diabetic, they are covered by their healthcare plans. But if they're not diabetic, then the patients have to pay for them themselves. And they can be quite costly, about $150 a month. There is a risk with these medications for a rare complication of pancreatitis and gallbladder disease, but again, smaller percentages. The other classification of meds, one of them is called Contrave. And Contrave is a combination of a medication that is used to manage alcohol and opioid dependency, and also a combination with an antidepressant. And this medication works more on the cravings. And so somebody that's craving food, they're not really hungry. It's not like they feel they've got a pit in their stomach all the time from the ghrelin, but these are people that are more just craving food, not because they're truly hungry, but they're craving food. This medication does work well for that. The side effect of this, though, is they can have lightheadedness and a little bit of nausea. And so sometimes patients have a hard time with those side effects. But it is a good medication for kind of the brain cravings. And that's how it works on decreasing the cravings, which then will decrease their food intake and then contribute to their weight loss. So those are the ones that come to mind right now.
Mm-hmm. Thank you. Yeah, there's a lot of options. Can you tell our listeners about bariatric surgeries, like what they are and what are the different uses?
Right. Good topic. Now, the thing with bariatric surgery is a person has to be eligible for it. So they have to have a certain BMI. And usually the BMI, it is the guideline that they still use for somebody qualifying for bariatric surgery. Bariatric surgery is covered by the healthcare plans. And the reason being, again, obesity is a chronic disease, and it has been recognized as that. So the BMIs have to be greater than 40 to qualify. The other thing is if they have a BMI greater than 35, but they have one of these comorbidities or these other health challenges, like they have diabetes, or they have coronary artery disease, or they have hypertension, or the obstructive sleep apnea, or the fatty liver, that would then make them more eligible with a BMI of 35. So the surgery that they used to do was called a gastric banding and adjustable gastric banding. And that's where they put a band around part of the stomach and they make the stomach a smaller little sac. And that would then decrease the amount of food that the patient can take in, because that band might be that they're only taking in 15 milliliters capacity. Literally 15 mils is 1 tablespoon of food. So they're eating less and less, more frequently, but like 15 mils of food, which is like nothing. It's 1 tablespoon. But they would expand that as the patient lost their weight. What they found, though, if you can just imagine the esophagus, when you take food into your mouth, we go down to the esophagus, goes down the esophagus, then it gets to what they call the lower esophageal sphincter, and then it gets into the stomach. And so when that band is right around the part of the stomach, that puts pressure up onto that lower esophageal sphincter. So what can happen is that patients can actually develop GERDs. So if they eat more than their 1 tablespoon of food, they're then having pressure build up into that lower esophageal sphincter and then into their esophagus, which we mentioned earlier can be contributing to exacerbating their asthma if they have asthma. So the band surgery, the gastric band surgeries are not done as much anymore. People have had them are out in the community and living with them, but we're seeing more of a vertical sleeve gastrectomy. And a vertical sleeve gastrectomy, ectomy means removal, gastric is the stomach. So they're removing part of the stomach. And what they do is it's half of the stomach that's removed. Well, actually about 85% of the stomach is removed. And it kind of just leaves a sleeve of the stomach. And the capacity then of the stomach is about 60 to 150 milliliters. Well, 1 cup of food is 250 mils. So really the capacity is just about half a cup, 150 mils. So they found that people do well with these gastric sleeve gastrectomies, and they don't have as many complications. So they can avoid vitamin deficiencies because they still have their stomach. So we see a lot of the vertical sleeve gastrectomy surgeries. And those are those restrictives. So the restrictives was the banding and also the gastrectomy. They have malabsorption surgeries, and these malabsorption surgeries are trying to remove part of the intestine so they don't absorb the nutrients, and that's how they would do weight loss. But what they found was these were not well tolerated. So what they have now as the one that they do most frequently or most common is called the Roux-en-Y gastric bypass surgery. And this is a combination of the restrictive surgery as well as a malabsorptive surgery. And what they do for this particular surgery is they make a small gastric pouch. So they make the stomach a smaller pouch, but they take part of the small intestine, which is the jejunum, and they take that small, it's a middle section of the small intestines, and they pull it up and they attach it to the small stomach pouch. And so what they're doing is people would swallow their food, it would go down their esophagus, into this small stomach pouch, and then go straight into the middle part of the small intestine. So it's bypassing like most of the stomach and the duodenum, which is the first part of the small intestine. And so what they found with this is that they would have a combination of a restrictive with only a small stomach pouch, and then some malabsorption because they're not getting the nutrients absorbed in the stomach or in the duodenum, but going straight into the middle portion of the small intestine called the jejunum. So that's called the Roux-en-Y gastric bypass, which is done most frequently. Now, patients that have gastric surgery have to be followed for life. They do have to be followed because they can be deficient in some of their vitamins. So they have to be taking vitamins regularly. They have to be very careful that they don't take too much food in because they can stretch their little pouches of stomachs, and they actually can rupture them as well. So you have to be careful, but they do lose weight, and they can lose 100 pounds within about a year of these surgeries. So that just gives you an idea of some of the surgeries and how they qualify. Do you have any questions about that, Habin?
Nope, I'm good.
Good, hey?
Yeah.
Good.
A tablespoon, that is just too little.
I know. And so consequently, they have to eat very frequently, and they have to be making the right choices. And so it's not a lot of our culture. You asked earlier about diet culture. We see a lot of people walking around with water bottles, okay? And everybody's got a water bottle, and what's in their water bottle. And when we're looking at some of these bariatric surgeries, we don't want them drinking fluids, because what they need is their nutrition. So you can't just have your 15 mils as a gulp of water. It has to be that you're getting nutritious food in, rather than the fluids. So that's something that following gastric surgery that people have to keep in mind.
For sure. And so body positivity has increased in the last couple of decades, but there is still that disconnection and misjudgment towards obesity. In what ways can the public work together to decrease weight stigma?
Oh, good question. So the biggest thing, if I could do a plug for patients suffering with obesity, is if people could just try to understand that it's not just diet and exercise. People can exercise, but exercise is a small portion of what's contributing to their obesity. Try to keep in mind that there's a genetic predisposition for weight gain. Thinking again of the twins, and thinking of the genetic component of 70%. The other thing is understanding the hormones. So if you think of ghrelin and think of peptide YY and also the leptin, these hormones are contributing to the fact that they never have satiety and they're always hungry. When you see somebody that is obese, try to think, I wonder what it's like to walk in their shoes. I wonder what their day-to-day life is like. And if these people have sore knees and sore hips and have poor sleep hygiene because they suffer with obstructive sleep apnea, they're tired during the daytime, they don't have the energy to get up and go to the gym. They can't go to the gym and start doing the treadmill if they have osteoarthritis in their knees and their ankles and their hips. So if the public, what can they do together, is to try to think of the other person with a sense of curiosity. I wonder what's going on in their lives. I wonder what it must feel like for them. I wonder what contributed to them getting to this point with obesity. Now, we're not speaking about mental health particularly in this session, but mental health, people that suffer with mental health issues or depression may be on antidepressants, and antidepressants as a medication contribute to weight gain and increased appetite. And so when you're looking at some of these medications, they may not choose to be overweight, but with the medications that they need to treat their mental health issues, that will contribute to weight gain. Another medication is prednisone or steroids. And people that suffer with COPD or chronic lung infections or chronic asthma, for example, if they end up being on a steroid, steroids also cause weight gain and water retention. So when you're looking at that, that can be a contributing factor for them being obese as well. So just having that sense of curiosity and trying to show some compassion of what these people might be living with. And the other thing with public, how can the public work together, is to try to promote having healthy foods available. So vending machines with snack foods that are healthier and also smaller portion sizes. That's what we need to be doing in terms of restaurants.
Thank you. And is there anything else you would like to tell our listeners?
I think the last point is just about the meal size. So when somebody's trying to lose weight or somebody has obesity, they're recommending that their meals should be about 300 to 600 calories per meal. And again, just 3 meals a day. So when you're looking at 300 to 600 calories, that's not a lot. Okay, when you think about how many calories you can eat if you sat down with a bag of chips, for example. They're also saying that the snacks should be about 200 calories. So 200 calories for a snack and about 300 to 600 for actual meal. And each meal should have protein. So each meal should have about 15 to 30 grams of protein. And people need to start looking at how do we measure that? How do we pay attention to that? And really almost need to be preoccupied with this 100% of the time to be trying to lose weight. And that becomes problematic for people living with obesity is they've got full-time jobs, they have kids, they're running a household, and that leaves very little time for actually calorie counting and looking at their foods and reading food labels. But what has changed in society, which has been just great, is food labels now showing exactly what's on not the ingredients, but the contents of the foods and the calories. And that has been a change. Don't quote me on that, but within about the last decade, all foods have to have those food labels to show exactly what's in it. And that's definitely been a very positive change in our society. So the information is there for people to track if they wanted to.
Perfect. And so, well, on behalf of our team, I would like to thank you for your excellent coverage on this topic. I just love how you have so much passion for teaching. It was really great to hear from you.
And it's good to see you again. So I wish you well with finishing up the last part of your program, and all the best. Thank you for having me. As we wrap up this episode, I would like to thank my team for sharing about diabetes and how it can be managed. And a big thank you to Brenda Lane for sitting down with A Sound Constitution to give some context on obesity. Lastly, I would like to thank you, our listeners, for joining me today. While it was a lot to cover in a short amount of time, I hope this was a good beginning to understand diabetes and obesity. As mentioned previously, for details and show notes from today's episode, or to follow along on what's coming up this season, check out our Facebook page at A Sound Constitution, our Instagram at CHLY A Sound Constitution, all one word, or our Twitter page at ASC_VIU. If you've missed parts of this episode, or would like to listen to this episode or episodes from previous shows, check out our YouTube at A Sound Constitution. Otherwise, we'll see you all next week.